an umbrella that's called JDTAN. And JDTAN is the Jamaica Diaspora Taskforce Action Network. So we are a volunteer organization, and we try to leverage expertise in the diaspora so that we can help our fellow Jamaicans back home. And one of the ways in which we do that through the Health Task Force is to present topics that may be of interest to Jamaicans based on their request. It so happened that this request came from the Jamaica Teachers Association through my partner, Roy Robinson. Roy, say hello, just wave so everybody can see you. And so we are doing this as a service to the teachers and other civil servants in Jamaica. So tonight we have a very special speaker. I say special because we went to high school together. We graduated from the same high school the same year, Dr. Maureen Tracy. And it so happens that we also worked at the same organization in Miami. So, you know, it's a special bond. And so I'm going to take the opportunity now to give you a little, to share a little bit about her. So Dr. Tracy is a highly skilled and well-established obstetrician gynecologist with over 15 years of experience practicing in South Florida. She is board certified and a fellow of the American College of Obstetrician and Gynecologists. Dr. Tracy received her Doctor of Medicine at the University of Florida College of Medicine and completed her obstetrics gynecology residency at Mercer University School of Medicine in Macon, Georgia. She currently works as a hospitalist at Baptist Health Homestead Hospital and is the chief of OBGYN. From 2009 to 2020, she worked at Community Health of South Florida and was the Director of Women's Services and Program Director for the OBGYN Residency Program. She has spent her entire career, there are people coming into the waiting room, so it's my eyes are going that way. She has spent her entire career dedicated to delivering medical care to the underserved patients of South Dade, Homestead, and Florida Keys. Dr. Tracy also has her MBA from Florida International University, my alma mater also, and an MS in biomedical science from Barry University. She enjoys reading, walking, traveling, attending church, and spending time with her family. So without more said, I'm going to turn it over to Dr. Tracy, and she's going to talk to us about menopause and also andropause, which is the male equivalent of menopause. So if there are any men, please ask questions. This is about you. So Dr. Tracy, you let me know when you're ready to start, and I will move your slides for you.
All righty, I am ready. Good evening, everyone, and thank you for inviting me to give this presentation, Dr. Frey.
You're welcome.
All righty. So I was asked to do this presentation on menopause, and basically menopause is can be a very difficult time in a woman's life. It can be very stressful, very confusing at times, and can create stress on the woman's life, on her family, and marriage. So the objectives for tonight is to get a better understanding of the definition of menopause. When does menopause occur? A clinical approach to the menopausal woman, and management options for menopausal symptoms. And at the end, as you know, I'm a gynecologist. However, I have been asked a lot about the andropause issue. So I have some basic information. There's not a lot of information on it. It's a new area that I think is still being studied. Next slide. So the definition of menopause. Menopause is a normal and natural event, and it's defined as the final menstrual period, and it's confirmed after you've gone through 1 year of no menses. So basically, if you have gone 6 months without having a period, and then your period comes back, you got to start all over again, counting those 12 months. So it is determined retrospectively after a woman has experienced 12 months of amenorrhea. And it is a permanent cessation of menses, and it results from the ovarian follicular function, loss of ovarian follicular function, and that's usually due to aging. So basically what happens is that the ovaries stop producing eggs, and you can no longer get pregnant after you've had this 12-month period of amenorrhea. Next slide.
Dr. Tracy, please use simple language so that everybody can understand, because not everyone in the audience is a health professional.
Right. Okay, will do. So when does menopause occur? It occurs naturally around, the average age is around 51. Okay, menopause can also occur prematurely because of a medical intervention. For example, if someone has a hysterectomy at a younger age, like in their 30s or 40s, and they have their ovaries removed, you will go into menopause. And menopause may occur due to impaired ovarian function. In other words, for whatever reason, the ovaries no longer function, and so they're not producing eggs. Next slide. So the signs and symptoms of menopause: change in the menstrual cycle patterns, vasomotor symptoms, and I'll explain what that is in more details, vulvovaginal symptoms, sleep disturbances, cognitive changes, and psychological symptoms. And we're going to go into detail with each of those.
Okay.
So basically, the signs and symptoms of menopause are a result of your estrogen level decreasing. Let's go over some terminology, because there is like a transition period getting to menopause. So you may hear the term perimenopause at times. And so perimenopause is the time around menopause. So that's before you start to have signs and symptoms of menopause. It tends to be the most symptomatic phase for most women. This is the most difficult phase, because this is the point where you start having the vasomotor symptoms, which are your hot flashes, night sweats, lack of sleep, that type of stuff. And it can be very difficult and create depression, as well as creates confusion and issues with work, issues in the marriage. And for most women who come in to me with this decision, they're so frustrated by the time that they come asking for help. Menopause, as we mentioned before, is a completion of 12 months without a period. And postmenopause is, once you complete those 12 months without a period, you're now considered postmenopausal. And that's the years after your final menstrual period. It can either be natural, or, as I said, it could be from premature menopause because of surgery or medication. There's also induced menopause. This comes as cessation of menstrual flow that's secondary to bilateral oophorectomy, which is basically removing both ovaries. Or if someone has cancer and they're going through chemotherapy or radiation, that injures the ovaries and they can no longer produce eggs. And then premature menopause is when menopause occurs before the age of 40, just from whatever reason, the ovaries no longer function normally and they're not producing eggs. So those are all the different stages and types of menopause. Next slide. So the menstrual changes that occur occurs both in the menstrual flow and in the frequency, as well as the duration of your period. So some women may have lighter bleeding, heavier bleeding, the length of the bleeding may increase, and the length of the cycle may increase or decrease, and you can have skipped menses. And all of this can happen in the same woman. Okay, and this is why it becomes such a difficult transition time, and can lead to women being depressed, staying at home, not, affects their social ability to just interact with others. Because if you're having super heavy bleeding, especially if you have flow that messes up your clothes, stuff like that, you're not going to want to go out. And just to let you know, can you go back to the other slide just for a second? Go back to the previous slide. Yeah. So basically some stuff that I can let you know is that the normal menstrual function during the reproductive years, like, it's usually 25 to 35 days cycle, right? So, but when we get into this premenstrual stage, then your cycle may become like 50 days. You get your menses every 50 days, or you, like we mentioned, you could have it within twice a month. You could have your menses twice a month. And then another time you'll be going 3-4 months without any menses. Now, the important thing to remember about this is that during this period, during this transition period where you're ovulating or not ovulating, having heavy bleeding, not having any bleeding, you can still get pregnant. A lot of women think that during this stage, they cannot get pregnant. Okay, but you can. So that's important to note. So, okay, next slide. So another thing that occurs is, let's talk about abnormal uterine bleeding. So abnormal uterine bleeding is heavy menses, especially with clots. Okay, the menstrual bleeding can last greater than 7 days, or greater than equal to, if someone is menses is like 5 days or 10 days, it's greater than equal to 2 days longer than your normal menstrual period. It can occur less than 21 days from the onset of one menstrual period to the next. You can have spotting and bleeding between periods, bleeding after intercourse. And the management for this is usually oral contraceptive pills or progestin IUD. Basically, it's like the Mirena IUD that has progesterone in it. And this is basically to level out your hormones. The key thing about abnormal uterine bleeding during the menopausal years is, before starting oral contraceptives or even placing an IUD, it is important to ensure that there's no endometrial cancer, because that's a big thing. And we'll talk about that a little bit more in the presentation, but just keep that in mind. Next slide. Okay, so vasomotor symptoms. Basically what vasomotor symptoms are, it's a recurrent, transient episodes of flushing accompanied by a sensation of warmth to intense heat on the upper body and face. This then spreads throughout the body and can last for 2 to 4 minutes. Sweating then occurs, then chills. Some women also experience heart palpitations and anxiety during this time. I'm sure, is anybody on here supposed to have that experience? Yeah. Okay, so hot flushes are more common at night. And when it occurs while you're sleeping, it's called night sweats. This may cause you to sweat through your clothes, wake up because you're either hot or cold, and this can make it hard to have a good night's sleep, and it leads to fatigue, irritability, trouble concentrating at work, and mood swings. I know people have told me that they've had to get up in the middle of the night, change their clothes multiple times for the night because they wake up and their clothes are soaking wet. These symptoms occur in 75% of perimenopausal women. And it's actually triggered by small increases in your core body temperature. The treatment is based on the symptom severity and a woman's risk and personal attitude about menopause, and also how well educated she is about her symptoms. Unfortunately, only about 20% of women seek medical attention. And that's very sad because there are options to at least improving these symptoms and having a better lifestyle. So before I get to this slide, there's some ways that you can cope with the vasomotor symptoms. And what you can do, because you have this hot, cold stuff going on, you can do layered clothing. So you can start out wearing, you know, a t-shirt with a sweater over that. And then, you know, you can remove your sweater when you start feeling hot. And keep your thermostat at home down at low. Avoid hot drinks. Other things you can do is you can put like a cold cloth against your neck, and that will help when you start getting the hot flushes. Remember, these symptoms are due to your hormones fluctuating at different times of the day and night. And it is it's a result of the fact that your estrogen level is beginning to decrease. Okay. Next slide. So one way of managing your vasomotor symptoms is by hormonal therapy. So hormone therapy is, again, the only pharmacologic therapy that is approved by the FDA and in Canada for treating menopausal symptoms. And hormone therapies can be either estrogen only and a combination of estrogen and progesterone therapy. So those are the two hormones that, the two reproductive hormones in females. Next slide. So basically, as we said, this has to be individualized for each woman, and it's usually for estrogen therapy. It's important to know whether the woman still has her uterus or not, because unopposed estrogen can be prescribed both systemically for women who do not have a uterus or locally in very low doses for women with vaginal symptoms. The reason for this is if a woman has a uterus and you give her estrogen, and that estrogen is unopposed, meaning that there's no progesterone to balance it out, that puts the woman at extremely high risk for developing endometrial cancer. Okay, so we give estrogen only to women who do not have a uterus. Basically, that's an estrogen pill, giving it systemically. Otherwise, we just give them the local, like a vaginal cream. Now, if you're using estrogen and progesterone, basically you're adding the progesterone to the estrogen to protect the woman who has a uterus, to protect her from developing endometrial cancer. So again, if you have a uterus, you have to have progesterone along with the estrogen. That's extremely important. There are also some bioidentical hormones, like, and most of those are over the counter, like estrase, that consist of hormones that are chemically identical to or very similar to the hormones that our body makes. Next slide. So there are some risks to taking these hormones, right? So the absolute risk of hormone therapy use in a healthy woman ages 50 to 59 are actually pretty low, but it includes them having thrombosis, which is basically a blood clot that may start in your legs and can lead to pulmonary embolism, which is a blood clot in your lungs. It can lead to stroke, and it can lead to heart attack. hormone therapy initiation in older women carry greater risk. Okay, and something interesting is that estrogen therapy actually has been known to lower the risk of breast cancer. So again, depending on if someone has a higher risk of breast cancer, like a family history of breast cancer, or they have like fibroadenoma or some precancerous lesion of the breast, the estrogen therapy may be a good idea for them. So basically, your physician should consider risk factors and what your priorities are before initiating treatment.
I have one question.
Sure.
Related to what you've been talking about. It says, a person with irregular period, is that person at risk in any way? What is this? More than a woman that has normal period?
No.
Okay.
The risk is the same.
Okay.
Yeah.
Thank you.
The only thing I may say about that is actually in younger patients, if they have a condition called polycystic ovarian syndrome, and this is where they get multiple cysts on the ovaries. These women are usually more obese. They have they produce increased amount of estrogen more than the average person, and they basically do not ovulate very regularly. So they may have their menses 2 to 3 times per year. These women are at risk of developing endometrial cancer. So that's the only situation where a young person could develop endometrial cancer. Give me 1 second, let me plug this computer in. Okay, next slide. So there are some alternatives to having hormone therapy if you don't want to do that, or if you have medical conditions that would prevent you from doing estrogen or progesterone therapy. And there are some non-hormonal prescription drugs such as antidepressants. Those are your SSRI, stuff like Zoloft, Paxil, Prozac. There's also antihypertensive drugs like clonidine that are known to help with these vasomotor symptoms. Neuropathic pain drugs like gabapentin, and Lyrica. Those have been known to help, and your anticonvulsants have been known to help. So there's lots of options for women to try.
One more question.
Sure.
What if a person was on family planning and comes off and still having irregular period? Is something wrong?
This basically, when you have, like, if you're on birth control to control your menses, and if you were on ovulatory cycle before, which basically means that you're having these irregular menses, and then you go on birth control to level off your hormones and basically get you to ovulate regularly every month. If you do come off the pills, you do reverse back to that stage. So if you have like young people, sometimes people in their 20s, and they have the unovulatory cycle, that we control that with oral contraceptive pills. However, once they come off that, they will go back to the irregular cycles.
Okay. Thank you. Next slide.
Yes. Now, other alternatives are your complementary and alternative medicines, such as your natural vitamins, soy isoflavones, your black cohosh. I'm sure you guys have heard of that. St. John's wort, melatonin to help with sleep, and just topical progesterone. Next slide. And my favorite, which is the all-important lifestyle changes, guys. You need to have relaxation techniques. You can do yoga, meditate, get in the habit of a healthy diet, regular exercise, avoid things that trigger hot flashes, such as caffeine, alcohol, spicy food, okay? Try to stay cool, as we discussed earlier. And as far as the sexual discomfort, because pain during intercourse, which is called dyspareunia, when you have vaginal dryness, this can be pretty distressful especially in a marriage. But you can reduce these by using moisturizers, lubricants, and vibrators. So a little bit more detail about the vaginal symptoms. So basically, because there's reduced estrogen, the vagina, the wall of the vagina becomes very thin. And this is called atrophy, okay? And this leads to itching on the labial area, the vulvar area, and itching inside the vagina, and dyspareunia, which is painful intercourse. And this is experienced by an estimated 10 to 40% of postmenopausal women. Okay. Usually the vaginal atrophy will resolve as time goes by. But treatment, again, is regular sexual activity, using lubricants, using moisturizers, and local vaginal estrogen. Now, some examples of that are, I wanted to show you guys something that I found this recently. It's called Bonafide. Let's see, can you guys see? This is something I've been recommending to my patients. It's good for vaginal dryness. And every time I recommend this to a patient, they come back very happy. It does not require prescription. You just have to go online and order it. It's a little pricey, but it seems to work excellent as far as lubricating the vagina and decreasing vaginal pain during intercourse.
Can you just hold it up one more time?
Yeah, let's see.
Towards the camera so we can back a little bit.
A little?
Right there, right there.
Yeah.
Okay, Bonafide. Okay.
Yeah. So basically what it is, I can open it up. The little suppositories. These little suppositories that you just insert in the vagina and then they dissolve. I usually recommend that my patients put them in at night only because sometimes there's leakage and you don't want to have that when you're at work during the day.
Okay.
So that's that. Next slide.
And one more question while we're transitioning to the next slide.
Mhm.
Woman who takes family planning and not seeing their period for a long time because of taking the family planning, how safe is that for knowing that individual is not passing out all that waste?
Okay, so yeah, so there's certain birth controls that can cause cessation of menses. For example, the Depo-Provera shot, which a lot of the young people use because it's a shot that they get every 3 months, and because of the progesterone in it, that can stop the menses. Also, IUD can do that. However, once they discontinue it, they should go back to being able to ovulate without any problems. Now with the IUD, you can the IUD is easily removed in the office, and you can get pregnant immediately after removing it within maybe a week or two removing it. However, the Depo is a little different. It could take up to 18 months after discontinuing the Depo to start ovulating and having those regular cycles where you can, if you're trying to get pregnant, that you'll be able to do so. So if you use Depo, you got to be a little bit more patient, and it's recommended only for people who don't foresee themselves wanting to get pregnant within, a reasonable amount of time after starting it.
Okay.
Okay, so sexual health. So these sexual issues, of course, they increase with aging. They're very distressing, and they start peaking at around age 45 to 64. As I mentioned before, it's the decrease in estrogen that causes a decline in the vaginal lubrication and the elasticity of the vagina, leading to the painful intercourse. Now, women have testosterone too. So the decrease in testosterone actually contributes to the decline in sexual desire and sensation. So again, what helps this is active sex life. So the more frequently you have intercourse, the more likely you are to have, moisture, your vagina have the moisture, and then using the lubricants, and of course vaginal estrogen suppository is extremely helpful. That's probably what gives you the best result, is the vaginal estrogen, because the estrogen causes the lining of the vagina to go back to its normal form. Okay. Next slide.
So guys, more sex, more sex.
More sex, more sex, yes. So, of course, there are sleep disturbances. We mentioned that earlier. During the perimenopausal and postmenopausal women, period women sleep less. They have more frequent insomnia and are more likely to use prescription sleeping aids. There is a decline in sleep quality that may be attributed to aging, such as nocturnal urination. In other words, as we get older, we tend to urinate more at night, okay? We have sleep-related disorders. Again, this can be from the hot flushes, just stress, personal stress in your life, and of course, the hormonal changes. Mm-hmm. So the decisions on whether to treat with behavioral or drug therapy is dependent on the severity of the sleep disturbance, the context of the sleep problem, and the severity of daytime consequences. In other words, if you have been so sleep deprived that you can't function during the day to, just get through an 8-hour day at work, then this will need to be addressed. I've known people to lose their jobs because they're not able to get to work because of sleep deprivation. They can't function the next day. Next slide. So, of course, cognitive changes comes with postmenopause again. So, we have dementia issues, Alzheimer's issues. So, basically, it's not really related to menopause. It's just related to normal aging, mood, stress, and other life circumstances. So that's where these cognitive changes come in. Next slide. Okay, so of course, your mood disorders are your feelings of upset, feeling like you've lost control of your life, of your family, being irritable, fatigue, having blue moods, and this is caused by the fluctuating hormone levels that perturb your neural system, basically. Women with a history of premenstrual syndrome, which is basically women who the premenstrual syndrome are the days before your menses start. If you tend to have be depressed and irritable during those periods, then you're more likely to have those type of symptoms during the premenstrual period as well. And this can cause significant stress, sexual dysfunction, physical activity or hot flashes are more vulnerable to depressive symptoms, and you become more vulnerable to depressive symptoms. There is a significant increased risk of new onset depression during the menopausal transition. So that's something that you need to be aware of. There's so much during this time, and it can lead to, especially if someone lives alone, the loneliness and just not being able to speak to.
Oh, we lost her. I think we lost Dr. Tracy. Sorry, guys. She was frozen for a bit. I thought she, let me see what happened.
Can you hear me and see me again?
Yes,
Hello?
we can.
Okay. I don't know what happened there.
Yeah, we lost you. You were
Yeah.
frozen and then you just disappeared.
Oh,
And you came back.
yeah. I think it was my internet. Just
Okay, good.
all
So you
right.
see, not only in Jamaica, we have unstable internet service. Okay,
It's
guys?
bad here. Yeah. Okay. All right. So next slide.
Okay. There we go.
Okay, so the most predictive factor for depression at midlife and beyond is someone who has a prior history of clinical depression are most likely to have severe depression during menopause. So what are some of the ways to manage this is, again, we keep repeating the same thing over and over again: relaxation, reducing your stress, using antidepressant, or even having counseling or psychotherapy to manage your symptoms. I'll put exercise in that too. That helps a lot. Next slide.
There we go.
Okay, so a lot of people didn't know that during menopause you have urinary symptoms as well. So women have urinary complaints, but this is more linked to it's not linked to menopause. It's more related to estrogen loss. 50% of women older than 50 years with urinary incontinence also report symptoms of what we call overactive bladder, which is basically an urge to go, and you can't wait, otherwise you're gonna have an accident. That's overactive bladder. Mild incontinence in early perimenopause tends to decline about 5 years after menopause. So how do you manage this? For women who are overweight, losing weight is effective. For stress incontinence, and stress incontinence is different from urge incontinence in that stress incontinence is what occurs when you laugh or you sneeze, or you bear down and then you have this leak. So you hear people talk about they laugh until they pee themselves or whatever. So one good treatment for this is doing what's called Kegel exercises. These Kegel exercises can help strengthen the perineal muscles to and help with that stress incontinence. So basically, what is Kegel exercises and how do you do them? So like I said, it's strengthening the perineal muscles. And how do you find your perineal muscles? The best way to do that is like when you're peeing, midstream, you contract your muscles to stop that pee. And when you do that, you'll feel the muscles, the perineal muscles. Now, once you feel comfortable that you know how to contract those muscles just by practicing doing it midstream, then you can do this exercise anywhere you want to. You can do it sitting at your desk at work, driving your car, in the mall. You could be at dinner and do these exercises. Now, the recommendation is to do these exercises like 4 to 5 times a day and do like 10 repetitions each time that you do it. Okay. And this is pretty effective. Now, for the overactive bladder, which is the what we call urge incontinence, which is your bladder gets full and you got to go right away. I know they have some cute commercials with those. Those have to be managed with medication. Okay. And I'm sure you've heard some of these medications. You see them advertised on TV all the time. You have your JDTAN. Some of the other ones you have is the Vesicare. So, and those are prescription medications. So, and then there's surgery that you can do where as OBGYNs, we can put in slings that help hold the bladder up, and that will help the incontinence as well. Okay. Here's another interesting thing that happens during menopause is osteoporosis, right? And osteoporosis is defined as compromised bone strength. So serious health threat for aging in postmenopausal women because it increases your risk of fracture, okay? 13 to 18% of white American women greater than 50 have osteoporosis of the hip. It is a result of lower estrogen levels that account for approximately 2/3 of bone loss during the perimenopausal period, which is 5 to 7 years prior to menopause. Next slide. So what are some risk factors for osteoporosis? Of course, advanced aging, a parental history of fragility fracture. And basically a fragility fracture is having a fracture of the hip, the wrist, and results from like if you're standing and you suddenly fall, okay? Other risk factors is female, especially white female, are at high risk. If you smoke, if you have a low BMI and you use alcohol, or if you personally has had a fracture of the hip. So now, basically, the highest risk person for osteoporosis is a very slim white female smoker who uses alcohol. That's you're gonna be your highest risk for osteoporosis. Next slide. Okay, so how do you manage osteoporosis? Here we go again, lifestyle changes, okay? And what are some of these lifestyle changes? Again, weight-bearing exercises, very good. Basically, you wanna change your diet, make sure you supplement your diet with calcium. And for women over the age of 50, it's recommended that you do a 1,200 milligrams of calcium daily with 800 milligrams of vitamin D. Okay. Other lifestyle changes, let me list some of these here for you. Is avoid smoking, exercise, and avoid alcohol, minimize your alcohol intake. So there is this questionnaire that you can take online that I would encourage everyone here to take it. It's called the FRAX. Basically, it's the fracture risk assessment tool. You go online, they ask you a bunch of questions, and then it will tell you your likelihood of having a fracture, a major fracture within 10 years. Okay. Some of the things that they ask you for information is like age, sex, weight, height, whether or not you had a prior hip fracture, if you smoke, if you drink alcohol, and then it will give you that. And the reason why I recommend that is that that score can determine whether or not, help determine whether or not you are treated for osteopenia or osteoporosis. So osteopenia is like the precursor to osteoporosis. So drug therapy is recommended for postmenopausal women who have vertebral or hip fracture. postmenopausal woman with a T-score less than or equal to -2.5 at the lumbar spine, femoral neck, or total hip. So basically, your T-score is the score you get when you do your bone mineral density test. Okay, so postmenopausal women with a T-score between 1 and -2.5, that's what's called osteopenia. Okay, so yeah, you're not quite at osteoporosis yet. So if you have a T-score of -1 to -2.5, and then your 10-year risk of major osteoporotic fracture is at least 20%, or if you have a hip fracture of at least 3% on the FRAX score, then it's recommended that you take medication for osteoporosis to prevent fractures. Next slide. Am I missing a slide? Okay, yeah, go back to the osteoporosis slide, because I wanted to mention what some of the medications were. So medications for osteoporosis are called bisphosphonates. And these are medications you see advertised on TV all the time. You have your Fosamax, which is a pill that you take monthly. And then you have, sorry, the Fosamax is weekly. Then you have another one called Actonel that you take monthly. Then there's another that you can take quarterly. And that one is your Boniva. Okay, and then you have the last one is the most recent one, which is the Reclass, which is an IV infusion that you do annually. So which of these is best for you would be something that you and your gynecologist would discuss. Next slide. So cardiovascular disease is something that increases during menopause as well. This includes your coronary artery disease and stroke. So cardiovascular disease is the second leading cause of death among US women aged 45 to 64. And the leading cause of death, a lot of people don't know this, is the leading cause of death of women greater than age 65. So when you hear about heart attack, everybody assumes that men are the ones that get heart attack, but heart attacks are the leading cause of death for women over age 65. And the symptoms are much more subtle than in men. Coronary artery disease deaths, the rates in younger women has been increasing, and this is due to obesity, diabetes, and high blood pressure. Next slide. So what's good cardiovascular health? Good cardiovascular health is keeping your total cholesterol below 200 milligrams, your HDL greater than 50 for women, greater than 50 for men, greater than 40, your LDL, less than 100. So the HDL is what we call the good cholesterol, which is needed to balance out the LDL, which is the bad cholesterol. You want your blood pressure to be, less than 120 over 80. Your fasting blood sugar should be less than 100. You want to keep that weight down to where your BMI is less than 25. Quit smoking. Vigorous exercise, about 150 minutes per week, which is about 20 minutes per day. So it's not a lot of exercise that you need to do to stay healthy. And 20 minutes of walking each day will do it. And of course, change your diet and eat healthy. I know that part is very difficult because as we work, it's easy to stop and get that fast food. But guys, you gotta discipline yourself to start eating healthy.
Quick question before we move on. And it's back to the period, the menses. Does a woman with a heavy flow, is a woman with a heavy flow prone to develop cancer of the ovaries than a woman with a normal flow?
No.
Okay.
No, the woman with a heavy flow may be more likely in postmenopausal period if you're having heavy vaginal bleeding, or concern is more for endometrial cancer, not ovarian cancer.
Thank you.
And we're going to discuss that. I think that's probably the next slide that we talk about that.
Okay.
Yeah.
There it is. The next
There it
slide.
is. Okay. So while menopause is not associated with increased cancer risk, cancer rates increase with age, and cancer is the second leading cause of death in the postmenopausal woman. So there are some cancers that we have screening tools for, right? Like breast cancer, colorectal cancer, and cervical cancer. Endometrial and ovarian cancer, unfortunately, there's no screening tools for them. So basically, for breast cancer, the recommendation is that you have a mammogram annually after the age of 50. For colorectal cancer, it's a colonoscopy starting at the age of 40 and doing it every 10 years. Actually, for African Americans, they have dropped the age. It was age of 50 and every 10 years for the average person, but for African Americans, you start at age 40 and then do it every 10 years. Now, there are other tests that can be done, like the fecal occult blood test, which is basically just smearing your feces on a little card that you send into the lab. That test can be used for someone who does not have a high family history of colorectal cancer. Then you have what you call sigmoidoscopy and a barium enema test that they can do. And those tests, they're not very popular, used very often, but those tests have to be done every 5 years.
Okay. Question related to that.
Mm-hmm.
Women who have fibroids develop cancer. I think you just answered that. And can ovarian cysts cause cancer?
Okay, let's talk about the fibroids first.
Okay.
So if a woman has fibroids are usually benign tumors. However, about 1% of fibroids can be developed into cancer. Okay, and usually those fibroids grow very, very rapidly. Okay, so and then as far as ovarian cancers, there are different types of ovarian cysts, and some of them are benign, and then others are cancerous. Yeah, so you have your simple cysts. Those are the cysts that you get like right before you ovulate. And then you have your serous cyst adenoma. They have all these fancy names. But basically, the adenomas are benign, but then the adenocarcinomas are the malignant ones.
Okay.
And as I said before, there is no screening tools for this. And we'll talk about what to do if we suspect this happening.
Okay. And then
cervical cancer. So let's go to cervical cancer.
Okay.
So we do have a screening method for cervical cancer, and that's the pap smear, right? So a woman should have a pap smear done every 3 years under age 30. At age 30, the new guidelines have us doing the pap smear and a HPV screening at the time of the pap smear. And if you're negative, pap is negative and the HPV screen is negative, you don't need another pap smear for 5 years. And after age 65, you no longer need a pap smear if you've had at least 10 years of a negative pap smear or never had an abnormal pap smear. So I know those are not the most comfortable thing, and women look forward to not having to do that anymore. Now for the endometrial cancer, as I was taught in residency, a postmenopausal woman or a woman over the age of 45 with bleeding, the differential diagnosis for that bleeding is endometrial cancer, endometrial cancer, endometrial cancer, the first 3. That's how important it is. Okay, so if you have bleeding, don't assume that it's because you're going through menopause. If you have heavy bleeding, you need to get checked out. Endometrial cancer is extremely curable and have a very high survival rate if you get it caught early. Okay. It's a simple office procedure, and it's doing an endometrial biopsy. A simple office procedure that can let you know if you have endometrial cancer or not. So there's no screening tool. However, if you go in and you have heavy bleeding, and this test will be done to determine if you have endometrial cancer. The ovarian cancer is a little bit more challenging because the symptoms are very vague. And usually by the time people start complaining about them, you have advanced ovarian disease. Okay, and the symptoms are like bloating. I mean, we all get bloating. What we call early satiety, which is basically as soon as you start eating, you feel full. You have loss of appetite, and then your abdomen starts to basically grow. And then when that happens, the diagnosis is by ultrasound and also doing a tumor marker called CA-125. Okay.
There are some questions related to cancer here, so let me just ask you. We talked about ovarian cysts already. Why can't a mammogram be done before age 40?
A mammogram can be done before age 40 if you have a family history of breast cancer. Usually, though, they start with a breast ultrasound only because of the density of the breast in younger women. The mammogram may be a little bit more difficult to read. So we usually start with a breast ultrasound and then either go to an MRI or the mammogram.
And the next, let me mute this person. Okay. The next one is, what is the lifespan of menopause? When does it?
For everybody, it's different. It could be a couple of years to 10 years. Some people claim that the menopausal symptoms never go away. Yeah.
Okay. And the next one is, please explain HPV and its contribution to cervical cancer.
Okay. So HPV stands for human papilloma virus. It is actually a sexually transmitted virus that has been found to be very highly related to cervical cancer. You don't have to have HPV to get cervical cancer, but most cervical cancers are caused by HPV. Now, the thing with HPV is it's asymptomatic in men. Okay. And even if a woman contracts the HPV, she may not show any symptoms either. And she could have HPV for years and not know it. So it's a dilemma if you do a pap smear on someone, let's say they've been married 5, 10 years, and then all of a sudden you're telling them they're HPV positive. The first thing that they're going to ask you is my husband cheating? And then I have to tell them that doesn't is not necessarily the case. You could have had this virus for several years. You could have had this virus, as a teenager. Most teenagers, young people up to age 30 will clear the virus, and that's something that they have noted, seen in the past, I would say maybe last 10 years. And that's the reason why we no longer do pap smears on teenagers. Before, a person was required to have a pap smear within a year of having initiating intercourse. Now, all women, no one gets a pap smear until they're age 21. And even if it's positive for HPV, we don't treat. We just monitor them. Okay. So we start treating maybe like 25 and above.
Okay.
There is a vaccine for HPV. that's recommended for, well, anyone can use it, but we recommend it for girls and guys. There's no one for men, before that they get it prior to starting sexual activity.
Okay. All right. We have several questions in the chat. So I'm going to make a recommendation that you finish the presentation.
Okay.
And I'm going to ask the audience to just remember your question, hold on to it, and at the end of at the end of Dr. Tracy's presentation, we'll have a question and answer session. All right? Thank you. Okay. So
Okay.
Dr. Tracy, you can go ahead. Let me go to the next slide.
Slide. Okay, so basically, in summary, the menopausal transition and the time afterwards are important periods for implementing your lifestyle changes and behavioral changes to ensure that you maximize your health. Okay, so that's the take home, guys. Start working out, start eating right, and just get that self time, your time for yourself, that you can relax, do something that you enjoy, like reading, dancing, that helps a lot.
Okay.
Okay. All righty.
Next.
So that's basically what I said. Okay, as far as sexual behavior, okay, so once it's menopause, you're no longer producing eggs, you can't get pregnant. But please, please, please remember to use protection, because you can still get sexually transmitted diseases, and that's real important. Okay, so you can get HIV, you can get chlamydia, you can get everything. A lot of these nursing homes where these people are just having fun, the sexual transmitted disease is high.
Yes.
Yeah.
Okay. So now let's go to the men.
The men. Oh my goodness. Okay. So there's not a lot of information out there on this, and I was researching it because, of course, I don't take care of men, don't know a lot about men's health, but I think this is a pretty decent summary of what andropause is about. So basically, andropause is just male menopause. And a lot of the symptoms are very similar to the symptoms that we women get. So it's basically an age-related reduction of the testosterone hormone. This sex hormone changes occur more gradually in men than in women. The testosterone levels decline about 10% per year after the age of 40. However, most men, no matter how old they get, they have normal testosterone. And that's why you see these men who are 80 and 90, they can still have children. Not so much for us. So only approximately 25% of men have low levels of testosterone as they age. Next slide. So most men are asymptomatic. Okay, they don't even know that they have low testosterone. Their sexual drive and sexual activity just remains the same. But the signs and symptoms that may occur, again, are not really related to low testosterone only. They can also be related to things such as medication and body habitus. So they recommend testing based on symptoms. There's no routine testing for testosterone levels. Next slide. So if you look at this list, the symptoms are pretty much the same as with women. You have decreased sexual desire and activity. Well, this next one, maybe not so much. Decreased spontaneous erections, height loss, hot flashes, decreased energy, depressed mood, sleep disturbance, decreased bone mineral density, and infertility. Right? So as I mentioned before, routine screening is not recommended. Testing for testosterone level is only recommended if symptoms are present. And even then, they recommend that you repeat the test at least once, preferably twice, once it's reported as low, to confirm the results are correct. Next slide. Okay, so testosterone therapy. This is interesting. Testosterone therapy may be offered to older males or symptomatic. It's not recommended routinely for older males with low testosterone levels if they're asymptomatic. It's just not recommended. And the next slide will tell you why. So maybe not this one. The American College of Physicians recommend treatment of men with sexual dysfunction who want to improve their sexual function after explaining the risk and benefits of them. And next slide. So here are the risks. They may stimulate metastatic prostatic cancer. So basically, before a male can be started on testosterone therapy for low levels, and because they're symptomatic, you have to do a PSA test before to ensure they're not in the early stage or asymptomatic stage of a prostatic cancer, because adding the testosterone can cause the cancer to rapidly multiply and metastasize. Testosterone can cause heart attacks, stroke, and deep vein thrombosis, which is basically a blood clot in the calves that can actually go to the lungs, causing pulmonary embolism and death. Next. And again, here we go back to it again, repeating the most common recommended treatments are lifestyle changes. Okay, healthy diet, regular exercise, get a good night's sleep, and reduce your stress level. And that's it.
Thank you so much. All right. So what I'm going to do now, I'm going to open up the floor. I'm going to stop sharing and open up the floor for questions. So
Okay.
you can write your questions in the chat, or you can use the reaction icon and raise your hands, and we will come to you. Okay. Let me see. Stop share. Okay. Wow. Beautiful. Okay. So Monique Francis, your hand is up. You can unmute yourself and ask your question.
Good night, everyone. As it is stated, I am Monique Francis. My question is, as you would have touched on the topic of HPV, it's actual that HPV is prominent in every man, but they are not affected by it. However, it does affect the female.
Correct.
It's not some men, it's every man, right?
No, I mean, not every man has, remember, it's a sexually transmitted disease, so not all men have HPV.
So how it is brought about? Because I was informed that it is the males are the carriers of HPV.
Correct, because they don't have symptoms, so they don't normally test males because they're asymptomatic, but it doesn't mean that all men carry HPV.
Okay,
right?
understood.
And that's why it's recommended that both males and females, prior to starting intercourse, get the HPV virus. It's recommended that the HPV vaccine. It's recommended that they get it at early as age 14.
Noted. Thanks.
Thank you. Okay, Christina, you're next. Christina R.
Thank you. Good night. I am Christina Ralph.
Good. Good evening.
Very enlightening presentation from both of you. I have a question. All right. Let me lay the cards on the table so you can understand where I'm coming from.
Okay.
I am over 60.
Okay.
And I am a breast cancer survivor.
Okay.
I did my surgery
That's
16 years ago.
Oh, wow.
My question, when I was diagnosed, I was just at the stage where I was going into menopause. So my question is, well, cancer is such a biggie, and at the same time, I also had rheumatoid arthritis, another troublesome one. So my question is, having had to do chemotherapy and radiation treatment, does it mean then that those big boys in the room would overshadow the menopause? Because like I don't know if I went through, I just know that I should have gone through, but my mind was just taken up with the cancer and the rheumatoid arthritis. And so, I don't know if you can shed any light as to what would have happened in that scenario.
Okay, so you may have gone through menopause earlier because of the chemotherapy and the radiation therapy. You may have gone through one of the topics that we discussed, which is premature menopause or induced menopause based on the therapy you had. But remember that not everyone has menopausal symptoms. Okay, the vasomotor symptoms that we talked about, the hot flashes and stuff, there are people who go through menopause and don't have any of that. Okay.
So you're basically saying maybe basically what I'm suspecting, that but the body couldn't deal with so many big ones, so the menopause maybe just stayed in the background.
Or you were so, like you said, you were so focused on the other
yes,
and pain from the rheumatoid arthritis that you didn't pay attention to the menopausal symptoms. But there are women who absolutely do not get any menopausal symptoms.
Okay.
Yeah.
Thank you.
You're welcome.
One observation before you leave. I was looking at the screen and I tried to check YouTube, but it wasn't there. So I guess the tech team will have to look at that.
Oh,
because
yes.
this
Thank
is
you so
very
much.
good, very good. Because I have so many persons who would like to have it. Thank you.
Thank you.
Thank you so much. We will make this available on our JDTAN TV website. Okay, it's being recorded, so we will just put it up there. Thank you so much. Now, there are some questions here. Oh, Simone, go ahead, Simone. Simone Williams.
Good night. I had posted this question into the chat. I was asking, a woman who is living with cancer, does the cancer changes her odor or her smell?
It shouldn't.
Great question.
What type of cancer are we talking about?
It's just a concern. I'm just asking.
Okay, it shouldn't really.
Okay.
Not unless like the cancer is like a stage 4 that's really causing a lot of degeneration in, like if you have a breast cancer and it's creating like a degeneration of the breast tissue. But I don't see where cancer is going to cause any odor.
Okay, thank you. I also have another question. Even though you said you did not have enough information on men that goes through prostate process, but is there any early sign? I've known this man, and when he found out that he had prostate, it was very late, where he was actually seeing blood and all of that just running down. Is there any sign that could show that, okay, because men on a whole doesn't really like to go to doctors. I realize men really don't like to go to the doctor's hospital.
Sure.
Is there any way they can detect that without going to the doctor?
Yeah, like you say, the blood in the pee is one of a late sign. There could be pain on when urinating. Mainly because the prostate gland ends up becoming enlarged.
Or difficulty urinating.
Yeah.
Okay, but you mentioned that is in the late part of
No,
it.
the blood in the urine is
Urine is the
probably
early detection of
advanced
it.
stage, right? But the difficulty urinating and the painful urination, those are some earlier signs that you may get. But
All right, thank you very
remember,
much.
is a screening test for prostate cancer, which is the PSA test that can be done. And I recommend that all men over the age of 50 get that test done.
Okay, thank you.
Okay, thank you for that question. We have some questions here in the chat. So the first one, do you need to do a pap smear if you have done a hysterectomy?
It depends. So if your hysterectomy was for a benign reason, like, you had your hysterectomy for fibroid uterus, then no, you don't need to have a pap smear. However, if your hysterectomy was because you had cervical cancer or endometrial cancer or vaginal cancer, then yes, we recommend, because you can have recurrence of the cancer in the vaginal canal. So a vaginal pap is recommended.
Okay, good. Thank you. Next question here from Monique. Is it factual that all men, okay, I think we answered that one already about HPV. Can having a cyst on your ovary cause cancer?
A cyst can become cancer. It doesn't cause this cancer, but can become cancer, Russ. Yeah.
A woman with cancer, does it change? Okay, we answered that one. Wonderful presentation. Thank you, Dr. Tracy. Thank you, Dr. Tracy. Very interesting. Great presentation, Dr. Tracy. Some of the info was new to me. Therefore, I applaud you. Great job.
Thank you.
Thank you, Dr. Tracy. Very informative. Dr. Tracy, can I have your email address, please?
Okay.
Do you recommend?
Like I said, because I'm fine with anyone. If you have any questions, you can email me, and it's Molly, MOLLY 62@AOL.com.
Okay, I'll put that in the chat. Molly62.
At AOL.com.
Where's my chat? Oh, here, it's right here. I'll do that. More questions. Let me see. Thanks for sharing information about perimenopause. The information is really informative. Thank you for taking the time to do this presentation. It was informative, very informative. Okay, I see two more hands up. Christina, you have another question?
Well, it's not really a question, but I believe that if I can answer a question based on my experiences, I should not shy away. The question that Simone asked, I just want to answer from my own experience. For me, I removed my left breast, and for the better part of 16 years, my left armpit did not produce sweat. So my doctor told me, my oncologist said I shouldn't put any deodorant there. But I noticed in the 16th year, I started to feel normal again. So sweat started to reappear. And as it relates to body odor, I have not experienced any undue odor. That would be abnormal, put it that way. Because you know that if you don't deal with sweat, it's going to become smelly. So I don't think I've seen anything out of the norm as it relates to body odor.
Thank you so much. Thank you. Andrea Thomas.
Hi, night everyone. Question: can hemorrhaging cysts cause cancer or any other disease or illness in women?
You mean like a hemorrhagic cyst?
Yes.
Okay, no, that won't cause cancer. So hemorrhagic cyst is basically There are two things that can give you a hemorrhagic cyst. Number one, just your regular follicle. During your menstrual cycle, you develop a follicle, and as that grows and ruptures to release the egg, that could have blood in it that sometimes will fill in, will expel if it ruptures into your abdomen. That can cause pain. It can cause your hemoglobin to drop. And in that case, if it drops really low, we may have to have surgery and just remove it, the cyst. But most times we can just monitor you. We admit you to the hospital, monitor you, give you blood transfusion, and eventually the bleeding will stop just from the clot putting pressure on the site. Another thing that can cause that type of cyst is endometriosis.
Mm-hmm.
And those are very painful, but they do not cause cancer.
Okay.
All right.
Thank
I
you.
have fibroids, but very small and like on the walls of your muscles, something like that.
Mm-hmm.
Very thin ones, like fibroids,
Okay.
and they're very less than 3 centimeters in size.
Mm-hmm.
Right, but there are quite a few. Should I be worried or?
No, are they causing symptoms? Like, are you having heavy
Yes.
bleeding with them?
Yes, I have heavy bleeding with them.
Okay, so if you have heavy bleeding, and there's certain options that you can have, like you can put in an IUD, like a Mirena IUD. That's the one that has the progesterone in it. That will help. You can actually do the depot shot, use oral contraceptive pills. All of that stuff will help with the bleeding. But if you want definitive therapy and you're done with your childbearing, then a hysterectomy is the next option, is the definitive therapy.
Right, because my sister did one, but not sure I'm clear on it because well, word has it that when you do a hysterectomy, you go into menopause very easy, and so the collagen, so aging takes place much quicker than normal. Can you say anything on that?
Okay, so that's going to happen only if you remove the ovaries. And the recommendation is if you're over 50 to remove the ovaries because you're probably close to menopause anyway. If you're under 50, we try to preserve the ovaries so that you can produce estrogen, and that will prevent you from going into early menopause. Sometimes when we go in thinking we're going to preserve the ovaries, we may see a cyst on it and we may remove it. And try to save one. Sometimes we can't. But also there's some women below 50 who just simply say that they want it removed because they don't want to have an issue later in life where they now have ovarian cancer and have to have another surgery. So they'd rather deal with the menopausal symptoms than keep their ovary. So it's a personal individual decision.
Oh, because I know of somebody that is 70-year-old who just removed their fibroids because they were causing pain.
Mm-hmm.
Right. So it does so the what you call that now, the myth that it starts the decreasing in size at menopause, is that a myth or is it factual?
It depends on the person. For some people, yes, it does decrease in size, but I find that for most people it's still there.
Okay.
Yes.
Thank you so much, Andrea. Dr. Wright, your hand was up.
Hi, good afternoon. Dr. Tracy, great presentation. Good afternoon. So I just want to follow up on the question, that the order question that Christina spoke about earlier. If an individual is on chemo or radiation therapy for whatever form of cancer, can that change the vaginal flora and therefore predisposes the individual to that the order that they spoke about earlier? Is that possible?
What's the best way I can say this? So it depends on the type of cancer and the chemotherapy that you get in. If it's for example, if you have your ovaries and it destroys your ovaries, then yes, you're gonna get what we call the vaginal dryness or the thinning of the lining of the vagina. And sometimes, and this is called vaginal atrophy. Sometimes what it does, you can get a discharge, you can get itching. And so sometimes when you have this discharge, you may have a slight odor. But I haven't seen anything that I would consider significant.
Okay. Oh, by the way, Dr. Wright is our Vice Chair for the Health Task Force. So thank you for being here, Dr. Wright.
You're welcome.
And thanks for the question.
Welcome.
Any other questions? Okay, I think that's it. So at this time, I'd like to say a personal thank you to Dr. Tracy, but Roy Main, my counterpart in Jamaica, is gonna do the official vote of thanks. So Roy Main, you're on.
Okay. A few months ago, the education sector started to realize a significant increase in illnesses and deaths. St. Thomas was one parish that has had its fair share of sadness. It was from this unfortunate reality that the resonant partnership was established between the JTA St. Thomas Membership Committee and the distinguished Jamaica Diaspora Health Task Force. So far, we have examined many topics and have had very good reviews and results. This evening, we are blessed once again with a fact-filled and engaging presentation on yet another hot topic. We are confident that the 20% figure of women who actually seek medical attention during this time will increase, as the participants will use this opportunity to get medical help. The alternatives and lifestyle changes will remain in our minds for a very long time. I believe some persons have discovered the possible cause of their mood disorders and have hopefully noted ways in which that can be managed. One thing is certain, and was duly established, that sex is not just another form of communication, but it is in fact a way of coping with menopause and andropause. Dr. Tracy, I am still in awe. And I am very sure that all participants are leaving the platform this evening with a renewed appreciation for self as they continue on this life's journey. Indeed, we are endowed with information which will not just help us as we enter into menopause or andropause, but we will be able to better assist and tolerate others as we embark on this rediscovery of self together. On behalf of all sectors, parishes, and countries represented here, I want to say a resounding thank you to Dr. Beverly Gordon and Dr. Maureen Tracy. We sincerely appreciate the time spent to prepare and facilitate us in such a remarkable way. I want to acknowledge team member Andrea Wright, Dr. Andrea Wright, and the support team. We look forward to more timely, credible, and relevant presentations. Colleagues, I join with Takeda in echoing this phrase: knowledge is not power. It is only a potential. However, applying that knowledge is the power, but most importantly, understanding why and when to apply that knowledge is wisdom. Have a good rest of the evening. Dr. Gordon.
Dr. Frey, I'm sorry. It's okay. Last week we had Dr. Gordon.
I know, Dr. Frey.
Not a problem. And I'd like to personally thank our support team, Antoinette Brown and Carlene Tomlinson. We could not have done this without you, so thank you. Thank you all so much for attending. In fact, this is our largest, this has been the largest audience we've had. So
Oh, wow.
thank you. Have
Thank
a
you,
good night.
guys.
And Maureen, thank you so much. Dr. Tracy, I can say Maureen because
Yes, please.
really, really. This was very, very informative.
Thank you, guys. Thanks.
Have a good night, guys.
And of course, feel free to, email me with any questions, additional questions that you may come up with, and I will respond.
Yes, and please join our task force. If you're a health professional and you would like to join our task force, I placed my email addresses in the chat. Please reach out to me. We need you. You have something you can share.